All right, hi everyone. My name is Tiara Brooks, and here at School-Based Health Alliance, we would like to thank everyone for attending today's webinar, Quality Improvement 101 Part 3. This webinar will conclude our three-part series summarizing the methods of primary care, quality improvement with a discussion of the engine of any project, a well-run regular team meeting. But before we begin, we have a few housekeeping reminders. The School-Based Health Alliance works to improve the health of children and youth by advancing and advocating for school-based health care. And we believe here at School-Based Health Alliance that all children and adolescents deserve to thrive, but too many struggle because they lack access to health care services. School-based health care is the solution, bringing health care to where students already spend the majority of their time in school. When health and education come together, great things happen. Attendance improves, conditions like asthma or diabetes are better managed, behavioral health issues get quick expert attention, and we all know that healthy students make better learners. First, please help us with our attendance count. If you are viewing as a group, please go to the chat window in the question box and type in the name of the person registered and the total number of additional people in the room. For example, Tiara Brooks +3. This will help us with our final attendance count. Also, all attendees are in listen-only mode. However, we want to hear your questions. To ask a question at any point during the webinar, please use the question box located in the GoToWebinar control window. We will address questions following the presentation. At the end of this webinar, attendees will be asked to complete evaluation poll questions. Please let us know how we are doing. Your feedback is vital in helping us craft presentations that meet your needs. This webinar is being recorded and will be archived on our website in 3 to 5 business days. Please also visit School-Based Health Alliance for additional archived webinars for topics such as the ones you are viewing on your screen. Please register today for our 2016 National School-Based Healthcare Convention and Rally. It will be held in Arlington, Virginia, June 26th through the 29th. We hope you'll join us for another year of innovative workshops and engaging speakers. Now we would like to introduce our presenter today, Hunter Gatewood. Hunter is a social worker and quality improvement educator and consultant. He specializes in the intersection of quality improvement methods, management skills, and leadership development. His clients include primary care health centers, hospital health plans, medical groups, behavioral health agencies, grant makers in elementary school and high school. His clinical experience includes hospital social work and community case management for patients with high care needs related to homelessness, substance abuse, complex medical conditions, and mental health. I would now like to turn it over to our presenter, Hunter Gatewood.
Great, thank you, Tiara. So yes, as Tiara said, this is part 3, the final chapter of our 3-part series here. Many of you have been on 1 or 2 of the prior ones, so welcome back. Good to have you with us again. If this is the first one you've been able to attend, that is great, and we will, and you're in the right place. Do you see my slides big?
Yes.
Okay, cool. And do you see the control panel? I don't know how to get rid of that.
No, we don't see it. You're good.
Okay, good. Okay, cool. Thank you. All right. So in part 1, we talked about the famous and often misunderstood Plan, Do, Study, Act cycle, the PDSA cycle, and how that fits into this quality improvement methodology. Part 2 last week was why this is all about processes of work, not about a specific project or a specific staff person or group of staff, but it really is to do quality improvement and get better, reliable results long term. We need to focus on processes, and that's what this quality improvement methodology is built to help us focus on and help us fix. And today, part 3, moving toward better care with QI team meetings. I want you to focus as we go through the next hour together on both of those pieces, on the team, how the team works, because the QI methodology is for teams. You don't need methodology, or you don't need much of it if it's just you doing your work and trying to get better by yourself. But in a team, you do need methodology, communication, habits. You need to do things in certain mutually understood ways, and then also focus on the other thing, meetings. We all go to too many meetings. A lot of meetings are not useful. So as you think about quality improvement, you can also think about how you can use the quality improvement meeting you witness. The team here is going to simulate a quality improvement meeting at about halfway through, and then we'll talk about it. As you think about what we talk about what makes a good quality improvement project meeting, think about how you can apply some of that to all the other meetings you go to. I think it's too easy to schedule meetings. If it were harder for people to schedule meetings, the operation of inviting people to meetings, if that were harder somehow, if you had to answer questions or jump through hoops to send that meeting request, I think we would definitely have less meetings, and I think we might be better off. So there are ways to take the lessons of quality improvement and what that means for change management into other meetings you go to. So I'd love for you to keep both of those things in your head. The way we're going to break down this next hour, we're going to talk about key ideas in quality improvement through this lens of having effective teams that have effective and strong meetings. We are going to talk about a little bit more about why we have meetings, what quality improvement, why teams require this methodology that I'm talking about here, and then we're going to actually have we have a treat for you at the top of the hour. The brave team from the School-Based Health Alliance is going to join me, and we are going to actually run through a quality improvement team meeting with specific roles for everybody and real examples taken from work that I've done in the past with improvement teams as an improvement coach. And then we're going to have a discussion. So the last 15-20 minutes will be discussion, but again, use chat as we go. As some of you already have, which is great. Use the chat or the question box. I think it is on this system. And we can get to those. Tiara or Selena, you can interrupt me as we go if you like, as questions come through. All right, let's jump in. Cool, thank you. So if you were on the other presentations, you've heard how we think about quality improvement as how we, those who work here, can do things better in the future, how we can change specific processes, actions, figure out who does what to get change at the system level. So quality improvement is focused on the future. We're looking for long-term, reliable results. We're not just thinking about what we can do in this project. And you'll see I put in a couple places here, just a couple, to commemorate the latest pop culture hero of mine who's died this year. 2016 has not been a good year for pop music heroes. When you think of Prince, you think of passion, purpose. You think of purple, you think of passion, purpose, and constant learning. One of the things that has kept his work so relevant and powerful for a lot of people, including me, has been that he played multiple instruments. He was always innovating. He was always trying new things, and he wasn't afraid to keep himself in that learner position. And those are things that really do apply to the world of QI and change management. So we're going to commemorate him a little bit here with that value. QI is different. Quality improvement is different. It's complementary, but it's different than quality assurance, which takes place in an inspection and audit way, and quality assurance points back to the past. Have you been doing everything right? Have you been meeting regulations, requirements, standards of care, standards of documentation? Outside of healthcare, there's public safety requirements and regulations that are all very important to us in industries such as food service. All restaurants need to meet requirements for temperatures in the fridge, how they handle the food they feed us. So quality assurance is very important. It's not the same thing as quality improvement. Quality improvement is us, the people doing the work, looking to the future, which is not the same thing as quality assurance. Okay. So these are a lot of the main concepts, the big picture, the main kind of overarching topics and concepts that we need to keep in mind as we think about quality improvement. Again, we talked a lot about processes last week. The system is the sum of all the processes that you perform in your clinic. Some of them have been redesigned, some of them are ripe for redesign, can't do it all at once, so you break down processes and work on each step, each flow of actions, who does what can we take off the provider's plate is very important now. When you focus on the process, it gets you out of the position as a team and as a manager, and you'll hear this in the QI team meeting in a few minutes. It gets you out of the position of focusing on whether certain people are doing the right thing or not. That's always a part of work, but the idea is that when the work isn't going well, when something's not happening that needs to happen, we want to focus first on the process and making sure that the steps are clear, and that we, skip down to the bottom here, that we standardize, we redesign and standardize things so that if I'm the brand new medical assistant in your clinic, I know exactly the right way to start a visit on time, get the vitals done, start the note perhaps in the EHR before the provider walks in. Whatever it is that you need to happen, if you focus on the process and make that clear, that really helps. So again, to invoke Prince here, you know, he's trying. Prince is a man who channeled love in all his music, and so that's another Prince quote for you. There's only one more coming, so if you don't like this, it'll be over soon. The other key concepts are population. We're not just focusing on who happens to come through our doors. We really are getting to the goals and the mission and the spirit of team-based care for a patient-centered medical home or a patient-centered health home type model, where we're responsible for the population, and that's what you measure. That's what you look at as you're figuring out if your quality improvement process is working. So those are examples of different populations and subpopulations that you can focus on to make sure that you're measuring the right group of people and helping the services be reliable for everybody in that group, versus, again, just who happens to come through the door in a given day or week or month. Using improvement methodology is important because we are working in complex systems where there's no right prescription. There's no one person who can just walk in and say, if you do all your processes and actions this way, you will get the results you want. Every clinic is different in terms of its staffing, in terms of its floor plan, number of exam rooms, the EHR you have. All your patient populations are different. People see different ages, different demographics, all that kind of stuff. So that's complexity, and that's why you need to adopt a management system with a methodology for people as groups to fix the processes. And then standardization I already mentioned. So these are just key concepts when you think about change management, when you think about performance improvement and quality improvement. We talked about this. If you're not getting the results you want, it's because of the way your system is operating, your clinic being the system, again, the sum of the processes. If visits don't start on time, if you can't, if you're not getting people to show up to your wonderful asthma group visits, whatever it is, you can break down the system into processes and redesign those. Not all at once. You can't fix everything at once. You shouldn't try. People get hurt that way. But think about what your system is giving you and what it's not giving you, and really dig into, really get creative and allow yourself to have some fun with how you redesign your system, versus just trying harder, versus fussing at each other, that kind of thing. Doesn't work. So think about the process and the redesign. That's really the spirit of improvement. Here's the model for improvement. There's an aim, there are measures, there are changes. You'll hear examples of this in the team meeting that we'll go into in a minute. But this is the structure, the 3 questions, and then here is the testing wheel, the plan, do, study, act cycle, where you want to do many tests of lots of ideas in a small way so that you can get to your goal. You can get to your measurable goal. The idea here is that, again, improvement requires a process and for the actual work of improvement, and that there is a structure. This gives you a structure for teams to work on together. So this will guide the team meeting that you'll hear in a minute, and this is the overall model that I teach, and I've seen it really work amazingly well in places. It gets rid of lots of frustrations. It prevents and solves lots of arguments. Please chat in now if you like any questions you have. I'm not going to walk through it again because we've done it in the past too. and you'll get examples, real-life examples in the team meeting that's coming up. But if there's any questions about aspects of the model for improvement, this would be a good time to chat those in. So I'll pause here for just a minute. Okay, we'll keep going. But again, please help us meet your needs by chatting in questions as they come to you. So we looked at these examples of measures, but when we talk about measures in the model for improvement, we aren't talking about annual measures. We're not talking about your UDS and HEDIS reports that are, very important measures. A lot of these measures here are adapted from HEDIS measures or could be, but we're talking about measurement that's frequent that helps you know how the work is going as you proceed. So here are some clinical quality examples. The reason I'm showing this here on a call about teams and meetings is not just because we want to do a little review here, but because when you think about these measures, this list here, every one of these measures, I strongly argue, require a team of people to improve them. Too much in primary care over the years, everything on this list has been the job of the provider to remember for that one person. And what we've seen in systems that perform really well is that it's, for most of these things, most of the things on this list right now, it's not the best use of the provider who's expensive and busy and trying to look for all sorts of clinical risks that the rest of us don't know how to look for. It's not the best use of that person to remember to screen and to do all these things. It's also not a good process to rely on people to remember, to busy people to remember things. So you want to set up systems, and again, you want to make these measures the responsibility of a team, and then you get into the process design and figure out how many people need to be involved, what can the medical assistant do perhaps, what can you do over the phone with the parents, what are the steps to really get these numbers high so that everybody gets reliable, good care. So if I'm a parent, and I have a kid in your who's being served by your clinic, I know that my kid, unless I have kept the kid out of the clinic and haven't been responding to prompts, unless I have, if I've been doing my part as a parent and my kid's available to the clinic, that my kid is, darn likely, very likely, maybe even guaranteed to get the well child visit in the past 12 months. So you know what reliability means, but that's the idea here, is that it takes a team to improve all these measures. And again, you need to use team meetings to figure this out. These numbers don't just get good on their own. That'd be great, but you can improve everything at once. So teams help decide which measures to focus on when, and again, how to share the work so that the numbers go up. Okay. As you'll hear in the team meeting in a moment, there are 3 uses of data. And like I said, for the measures list, only improvement do you always need a team to do the work. Research is important. Measurement for judgment is important. Judgment, another word for that, is this is the way you measure in quality assurance when the auditors come in and make sure that you're worthy of being a clinic where people come for care, that you're meeting the minimum standards, and your charting is up to date, and you're meeting HIPAA, and charts are behind 2 locked doors, all that kind of stuff. That's judgment and measurement for judgment. It's important, but it's not the same thing as measurement for improvement. And then measurement and the difference between data for improvement and data for research, let's go into a little bit more on this next slide. Here's the distinction here. So again, we're not trying to eliminate bias. We're not trying to determine absolute causality between our intervention and the change we're seeing in our numbers as we measure frequently, as we would for research. We're not trying to throw out outlier data. We want to look at that outlier data. If it's an accurate number of what our cycle time is for how long a visit takes, or if it's an accurate number for how many screenings we did or didn't do for depression, or how many well-child checks we did in a month. If we had 0 well-child checks in a month, and we usually have 20 to 30, that 0 is really important. We need to see what happened there. So whereas in research you would throw that 0 out because it doesn't fit, or it's an outlier data point. So that's just one little example of what we actually do when we look at data and improvement. But you see here the distinction between using numbers for research and numbers for learning and improving. Okay, and we can take questions on that at any point too, especially if there are some researchers, public health experts, or people who've done clinical research before. All right, so we're getting into our team meeting, and let's see. So here's what you're going to see, and here's what you want to look out for. In any good meeting, you have specific tools you use, specifically some sort of agenda document, whether you're keeping up with it online, on the computer as you go, or if it's an old-fashioned handwritten one. So that's one of the tools that you also use in a quality improvement project. You'll see the agenda form. There are other tools like the PDSA form and other things that are important for any quality improvement project to be important. These tools guide the discussion. They keep the team together. They keep the team focusing on the problem and the opportunities versus a lot of meetings I've gone to over my professional life. You show up in the room and everybody just brings in their notebook, their smartphone, or whatever they've got in their hands, and they sit down and everybody just talks. And some meetings I've gone to, nobody even takes notes. Not a good meeting for anything, especially not for, and even not for a QI project either. So you want tools for your project, you want tools for your meeting. This next slide is important when you think about change management and having a productive team. You do want conflict. You want people to disagree. I'm from the South, and it's always very important. It was important to me growing up, and important to my family, especially my mom, that everybody get along. And we certainly want to get along, but that doesn't mean that we shouldn't try to surface disagreement, because when we don't surface disagreement in the meeting, it's going to come up somewhere else. So you end up having the meeting after the meeting, where two people huddle around the door and say, well, she said this, and I didn't like that, and what about this? And what ends up happening is the whole process gets undermined. The team doesn't trust, the meeting isn't effective. The meeting doesn't work for what you need to accomplish, and you can end up, wallowing around in politics and power struggles, and also the work just doesn't move along. Ultimately, the work doesn't move along, and you can have some conflict under the rug, which isn't good. So in a good team meeting, it's safe for people to disagree. You want people to disagree, because if we all agreed, then what would be the point of sitting down and talking together? If everybody had the same brain on everything you talk about, then everybody could just stay in their desks and the whole thing could be accomplished by one person. But of course, that's not the real world. That's not how humans operate. So productive conflict is really important, something I personally had to get more comfortable with and more adept at managing in meetings that I run, and it's very important to quality improvement. You want people to have different ideas. You want a clear aim. Why are we even in this meeting? Why did I come into this room? QI projects have an advantage over lots of other meetings in this way. You come together as a quality improvement team because you have an aim statement. In the example you'll see in a minute, the team is working on visit efficiency. So they have a clear aim that they'll show you. You want meeting hygiene, which includes starting on time. It includes using an agenda form. It includes some other things you'll see in the meeting. I won't spoil everything they're going to talk about. You will see an active discussion of a PDSA test completed. What we talked about in the PDSA webinar 2 weeks ago, you do the plan of a PDSA and you do the study and the act as a team. The do happens, the actual execution of the test in the real world, that happens by one or two people, and it can't happen in a meeting. You can share opinions and make predictions, and you should, but the do actually has to happen out in the real world of care. That's how you actually are doing a live test. So what you'll hear is they'll discuss what happened when the test was run by two of the team members, and it's a cool one. It's a cool discussion for the study and act they'll do. And then they'll also look at data. They'll look at their main run chart for the main measure, cycle time, that measures how well how well they're doing in trying to meet their aim of efficient visits. This is a school-based health center clinic team, this fake QI team we put together for you today. And so cycle time matters in school-based health, of course, because you don't want to keep kids out of class or lunch or whatever any more than you have to. That's important for the kids learning. It's important for the relationship with the school. So they'll talk about the data, how that's going, and then I hope you hear that it's a good group. There is excitement in the team. They've done a good job putting this meeting together for you. You want to hear excitement. This, often quality improvement team meetings I've seen, once the team gets in the groove and understands how to do PDSAs and how to disagree productively, these are some of the favorite meetings they go to. They'd rather go to this meeting than other meetings. If Prince were on your QI team, he would say, and this is the last Prince reference, if Prince was on your QI team, he might say, all I really need is to know that you believe. I don't know if he'd die for you in a team meeting, but it's all about excitement. Again, why are we here? What's the mission? What's the aim? How is this going to help our population? And connecting the activity in the meeting to the population you're serving is very important for commitment, excitement, follow-through, buy-in, and change management, right? You want people to think it matters because they need to be in the room for their own reasons as well as just because you invited them to the meeting. All right, so that's all the good stuff you're going to look for. And one more note about the relationship of the pieces of the model for improvement before I turn it over to the group, and I will advance the slides for them. When you're doing PDSA small and quick, you'll hear this in the meeting and see this playing out as they fill out their PDSA form. You're not expecting the improvement measures to change because you're doing the PDSA. In this case, it's with one patient and one visit. This is really important as you think about how the different pieces of the improvement model, the methodology, relate to one another. Once you finish testing and you decide, yeah, we figured out the best way to do this particular change idea. In this example, they're testing agenda setting. We've tested it and we figured out a way it's going to work. Then they implement it, and then you watch your numbers for the measure you're trying to impact with your change. Then you watch the numbers and see if they go in the right direction, because only after implementing a change that you've been testing is the change going to happen routinely, regularly, every day across multiple patients, probably, in order for it to actually help your numbers and the measure go in the right direction. So these are some examples of changes that you can test. So I hope that's clear. We can get back to that in the Q&A if you want, but I wanted to put that in your heads because now we are going into the team meeting. I want you to meet the improvement team from the Visionary Clinic. We had I didn't have time to put my photo in here, but I'm subbing in as Anna, who's another brave member of the School-Based Health Alliance staff who's home with a bad migraine and was willing to join us, but we decided that was too much punishment for a willing actor, so we let her off the hook, and I'm going to sub in as Anna, a medical assistant. We have Tiara at the front desk. We have Erin, who is a lot of you know, I think. And she's the team leader. She's the enthusiastic champion for quality improvement, and she's going to be managing our agenda in the meeting. And then you have Larry, who is the site manager. He is the voice of experience at Visionary Clinic. He's seen it all, and he's on the team as well. So that's an important team member to have. So we are right on time, and so now I'm just going to team lead Erin. I am going to advance to the next slide, and we will let you kick off our team meeting.
Awesome. Thanks, Hunter. All right. So everyone, thank you for joining our weekly 15-minute QI team meeting. I'm so excited that we're working on this project to increase vision efficiency. You guys know I love this stuff, and you know that I love that our work is ultimately going to improve care for our patients. So let's just quickly ground ourselves in reviewing the overall aim of our work. So by April 1st of next year, our clinic will improve care for all our patients by achieving efficient visit flow with an average visit cycle time of 60 minutes or less.
Right, and I'm thrilled that we're doing this. I have to say, we tried this about 10 years ago, and there was enthusiasm then, and I'm hoping it'll be different this time.
Well, Larry, it's so great to have you on the team and have your experience here. We certainly want to make sure that we're moving in the right direction, and we want to make sure that we're continually building on our experiences and what we know, and that we're ultimately improving. So let's kind of get a little deeper into our meeting agenda, because I think one of the things that's different about this project compared to previous projects is that we're using the model for improvement to really help solidify and document all the work that we're doing.
Hey, Erin, I'm also excited to be on this team. This is Hunter, the new medical assistant. I'm just wondering, don't we, because Larry worked on this, or people worked on this at the clinic 10 years ago with Larry. I just wonder, I'm new here, and I feel like there's got to be a right way. Like, don't we know that already? And can't somebody just tell me what I'm supposed to be doing?
Well, Hunter, we're so excited to have you on the team as well. So you get the awesome opportunity of being on the team where you're going to help us figure out what to do. We're going to use you in the changes. So not every change, not every idea works with every person in every clinic for every solution. So we're really here to put all of our brains together and figure out how to make this happen in our clinic.
Okay, cool. Thanks. I still think there's got to be a right way to do everything, but let me, yeah, I'll just thank you. I'm excited to be here. Let's see what happens.
All right, well, we'll come up with our next steps together. So let's just look at our agenda and review what we did last week. So last week we all met in our weekly 15-minute team meeting, and we talked about, we planned a PDSA on agenda setting. So I'm going to have Tiara, our front desk person, just explain this in a little more detail, but we want to talk about what we talked about last week, how it was implemented in the do, and then today what we really want to do as a group is study what happened, what were our reactions since Tiara and I were involved in that test. Anna and Larry, you bring such great perspectives to this. We want to hear your thoughts. We want to look at the data together and then determine our next steps for this work.
Well, Erin, thank you for including me in this meeting. Well, when we handed out the form for the morning patients, it just seemed a little confusing for the patients. And some of them didn't really understand the form. And when trying to explain the form in more detail to some, I kept getting interrupted by the multiple phone calls that we had from patients. It just seemed difficult to try to balance between trying to attend to the patients that seemed a little frustrated with the form and also trying to make sure I answer all the phone calls that come in.
Awesome, Tiara. Thank you so much for that feedback. And I kind of got some of that too. There was one point when we were testing this on Tuesday where I was waiting to call a patient back to the exam room, and they were waiting to talk to you, but you were on the phone and they hadn't completed the form because they weren't quite sure what to do. So let's review quickly just kind of what we plan to do, couple that with how it actually happened, and see if there are some adjustments or shifts that we can make. So on Tuesday, Tiara worked with patients, as she said, to hand out this agenda setting form and that they would fill it out while they wait, so that by the time they came to me in the exam room, everything was prioritized for the visit and I could really efficiently get into the needs of the patient and deliver care as streamlined as possible. So Tiara expressed that there was some confusion about the form. People weren't really clear on what that meant. And I know that, Tiara, you felt like you were being interrupted and it was hard for you to do your job and explain to the patient.
I enjoyed doing this, but the PDSA did not go well for me because it didn't seem sustainable or good for patients. Could we try something else? People seem to be in the waiting room a lot longer in the afternoon, so we should test in the afternoon as well in the morning.
Tiara, I am so happy to hear you say, like, maybe we should try something else, because I do really like this test. I think that it has the potential to shine. We just need to work out some of the kinks of actually testing it on a small scale and operationalizing what we want to happen. So, Hunter.
Right. I can see the value of trying these improvements. I just worry there's a lot of inertia to get over.
Yes. Yeah, so maybe this is a good time to switch and kind of look at our data that we've been collecting in this project.
Okay.
That may help us keep our momentum going, Larry, and point us in the right direction.
Okay. Well, and Erin, I wonder, while we're looking at the PDSA form here together and deciding on our next steps, I wonder if well, first of all, I get it now. Thank you. This is cool. I understand why we'd want to test it on one day versus just implementing agenda forms, giving Tiara a stack of agenda forms to give out every day, that would have been a really bad move, and it would have been really frustrating for her, particularly, and for patients, sounds like. I wonder, as we think about what to do next, there may be a role for me as a medical assistant. I hadn't thought about that before, but there may be a role for me as the medical assistant in the step of our process between Tiara giving the patient the form and the discussion of it with the provider. So as we think about future PDSAs, either right now or after we look at our data, I think that would be, I'm interested in helping do a test. I think this is really neat.
Awesome, Hunter. That's great. So I see there are 2 suggestions thrown out on the table. Tiara is saying that maybe we need to change the time of this test because of the how busy the wait room is.
Yes, and Erin, and what about could we try a script that's maybe consistent across the board and do it in the afternoon where the waiting area is a little busier?
Okay, so there's a couple of ideas out here on the table. This is great. So we've got, maybe we need to look at implementing this test at a different time to see how busy the waiting room impacts the ability to deliver this. We need to get Tiara a script that's concise and clear so that she can efficiently explain to all of our patients why they're getting this agenda form. And then we also need to think about how can we better utilize Hunter as the MA in this work. Is there a step in between Tiara giving out the form and when I'm talking to our patient in the exam room?
This is hard to keep straight for me, but I'm trusting that you guys can do it.
Well, Larry, I think, let's keep talking about it. I think these are all examples, just looking at the form here. Yeah, what Erin's leading us to is adapting, right? It's we're going to test again with a change, and I think we can. I'm excited, but I want to see what happens with the script for Tiara. So in order to kind of keep going on our current trajectory, what if we decide to test it again with the script?
Okay, biting it off in little chunks.
Exactly, testing one change at a time, one change at a time to the test itself, which, we could do it in the afternoon if Tiara thinks that's better. I don't think that that's too much, but I think the script first, and then maybe pull me in, if that sounds useful, pull me in after we see how the script works.
This is great dialogue, and this is exactly why we do PDSAs. We want to be able to bring in different players and get different perspectives. By testing small, we're able to really try a multitude of different ideas. Because we're testing them so small, it lowers the risk. It's easier to recover if they don't work, and it's easier to see what works and what doesn't to guide us in our next steps. So this is great discussion. I'm glad that you all are on my team.
And I have to admit, I was slightly hesitant, but I really appreciate the input. Sometimes the front desk is forgotten about.
Well, you're an important player in this work here, so we're happy to have you on the team. So does anyone on the team have any other questions about the Plan, Do, Study, Act form, or should we kind of shift now and look at our data and see if that helps guide our discussion?
No, I'm excited to hear what happens with the next PDSA. But I think that's a good plan to work on the script. Tiara, I don't know anything about agenda setting, but I can come. What if I come to the front desk during lunch today, and maybe you and I, or if you and Erin can work on it, or I'm happy to help work on the script with you.
I really appreciate that. Anytime that you have, will be more than welcome.
All right, cool. I'll find you at the front desk.
All right, great. So this is where I really get excited, which I keep pulling back to, is our data. So, every week we've been looking at these data points to our appointment cycle time, and we've already done a couple of PDSAs. So we had our Vitals in the Room PDSA, which you can see helped decrease our cycle time once it was fully implemented. Then we had Hunter scribing for preventative care. So that we implemented just at the beginning of last month. It's been a little over a month since we've been doing that, and we are seeing some improvement there. What I really hope is that we keep going with this agenda setting form, and hopefully that can also show some increase in the cycle time as well. We don't see it quite yet because we're testing on such a small scale. We want to make sure that this this agenda and the script that we're talking about implementing are really perfected before we continue to scale up. But it does look like we're getting closer and closer to achieving our goal of the 60-minute cycle time. If you look at that red line there on the chart, that's our median time. So right now our median time is 78-ish minutes, and as you can see, when we started this project, we were at 100. So we are going down, and we're getting ever closer to that 60-minute cycle time.
Great, and it looks like to me that whoever prepared this chart for us, some guy who lives in California, put our goal at 55 minutes. So that's an even more ambitious goal, and that's great. We're close to it. As the MA, I like to see, it's always great. I like to see us reach our goal, and so it's helpful to me, Erin, to hear you say that even though we haven't reached our goal, we haven't hit that green line yet of our goal short visit with a cycle time of 60 or really 55 on this chart. That we're very close to it, that we're moving towards it, and so because I was feeling kind of discouraged because I peaked at this before and saw that we didn't hit our goal yet. So it's good to hear that using the median line, we can tell that we are getting closer, and that the two things we've implemented are making a difference.
Yes, that's great, Hunter, and it's important to recognize that our aim is kind of our long game, that's what we're shooting for in the long run. So we'll do lots and lots of these little PDSAs, all with the ultimate goal of hitting that 60 or 55-minute cycle time.
Cool, this is exciting.
So Tiara and Larry, I know that you both are a little bit hesitant about this work, but would you be willing to do another PDSA and we can plan it to test again with some of the few changes that we've talked about today?
Oh, sure.
Yes, definitely.
Okay. Yeah.
Great, and Hunter, it would be great if we can pull you a bit more into this work as well. So perhaps when you and Tiara are talking about the script, you and Tiara can also think about how to pull you into this work and have you fill that gap between Tiara and myself.
Great, I'd be happy to. Yeah, this is cool stuff.
All right. So just looking at our agenda, I'm going to put in that we will do PDSA number 2 with the agenda setting form, but this time we're going to add a script for Tiara, and we have a few tasks that are going to happen before that. And let's do that next Tuesday, shall we?
Yes.
Okay, great. And then, Larry, I know that this work is very important to you because you've seen this clinic go through a lot of changes, and also looking at, efficiency has always been something this clinic has been worried about.
Always a goal, at least.
Yeah, so we would, if it's okay with you, I'd love to talk to you about how to create a progress report that you can share with the wider organization to let them know what we're doing and where we're going towards.
Well, I think the trend of the what we call our chart, the run chart, is good, and that's going to be easy enough for people to see. The rest of the staff, I mean, and of course, the senior management. That's their hope as well. I think some people might worry that, or might ask, or worry a little bit that we might be losing something when we make these changes, and we don't want to throw the baby out with the bathwater. And so I'm a little concerned that I'll get questions like that I might not be able to answer. But if you guys will support me, I'm sure we'll do fine.
That's great, and I think again, this is an opportunity to have our larger organization buy into quality improvement work. We don't want to throw the baby out with the bathwater, and that's why we're making sure we aren't changing too much too fast. We're starting with really small incremental changes that we can build up over time. And so, Larry, I'd be happy to help you with some PDSA talking points so that we can get our organization kind of understanding this culture of improvement.
Okay, that'd be great. Thanks.
All right, any final questions before we adjourn our 15-minute meeting? Nope, I'm ready. All right, go team, go.
Okay.
Sounds good, sounds good. Okay, and scene. So thank you again, actors. You guys are amazing. I realized after I put this plan in motion how much work this was going to be for you three, and for Anna before she had to have a sick day. So thanks again. That was great. I hope that was useful to everyone on, everyone listening. I hope you've sat through similar meetings that have been productive and exciting and goal-oriented and interesting, and where you've learned things. I'm sure you have. Right, and so now we have the whole rest of the next 10 or 15 minutes to dig into anything about teams, about meetings, and about quality improvement in general. PDSAs related to data, any of that stuff you want to talk about. We have 15 minutes. Please think about what you want to ask. But before we do that, we are going to do our 3 poll questions for the day. So we're going to have those poll questions. So please pay attention.
Yes. So we'd like to get some feedback from you guys and get you a little involved. Please name 3 things is good a QI project meeting needs are. I know this may be a tough decision for some of you. We'll give you about 5 more seconds.
Thanks.
We just want to hit that snacks button.
Everybody needs snacks. Yep. Great. So thanks everybody for responding to the first question. Yes, 93%. Good. 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 We had a few people, maybe 3 or 4, answer option 2, which includes 2 of the 3 elements that I put in the right answer. The answer I think is most correct. You don't. The difference here is the manager. You don't always need a manager on a quality improvement team. I would say that's more true. You don't need the manager once that engine and what Erin talked about as the culture of improvement or the culture of quality. Once that engine of quality improvement, the methodology is in place, people know why we're doing these projects, what the point is. The point is, again, sustained long-term change. Once that culture and rhythm is set in the organization, you need managers less. But you certainly need, whether or not the manager is in the weekly quality improvement meeting, you certainly need managers to help support you, make sure you have the time to meet, for example, make sure you get the data you need as they can help with that, and be on the lookout. They need to support you. We got into this on the first webinar, I think, in response to one question. It really is the manager's job, if they're supporting you in doing quality improvement, they need to understand that coming back to them will be your ideas for changes to make, and for those that don't cost a lot of money and aren't going to totally upend one person or multiple people's job descriptions, it's their job to really help those changes happen. So you do need manager involvement. You do not necessarily always need a manager in every week-to-week quality improvement meeting. This is about frontline staff being experts themselves in the work. So frontline teams, I've seen really good work happen. I saw one project I'm involved with now about really complicated work of opioid prescription management in adult primary care. Of course, you all know there's a huge national crisis because healthcare has been over-prescribing opiates for a lot of years, and now a lot of these people are addicted. That work is being led by a medical assistant at a clinic that I'm working with right now, and he's able to steer leadership, including the CEO of the clinic, who's very focused on this topic because it's very important for safety and for all kinds of reasons. But the MA is leading that project. Okay, so long answer to that response. Thank you. Next poll question.
Yes, QI team meetings are a great place to bring.
Okay, great. Thanks for all the responses. So yes, my idea for the best answer here is all of the above. As you heard the team at the role play that we just did, the meeting that just happened between Aaron, Larry, Tiara, and myself, Tiara and Aaron brought back the do. They brought back the report on what happened. They did the test, and again, you need to do that study. The study and act need to be part of a team meeting or at least a team discussion, because you don't want one person deciding whether the test worked or not. You want everybody's opinions so that you figure out what was valuable in the test and what the adaptation might need to be. Or if if it really didn't work and you don't want to do it ever again like that, if that change idea didn't work for you at all, then that's important. That's an important team decision too. So that one, yes, definitely bring the do to a team meeting. You definitely want to bring competing ideas for sure. Again, if everybody thought the same way, that you wouldn't really need to meet. And then the special guests, these are other people you may want to bring, who aren't part of the QI team meetings every time, who aren't part of the core team of 3 or 4 or 5 people. These could include other MAs. You might want to bring another MA to enlist another MA as you do more PDSAs. As you test things, part of the adaptation and the different conditions for testing should include different staff. So you could bring in another provider or another MA to test things that Anna or me as the MA in this team was talking about testing. You want to test it with multiple MAs because I work differently than other people as an MA. Different providers work differently. So again, before you decide to move from testing to implementation, other people need to do PDSAs with you, and you might want to bring them in to talk to the team about why you want to use them in this way. But they don't have to come to the meetings every week. You could also bring your finance person. Your finance person could help you think through changes. If your project really takes off and you start talking about changing in staff ratios or new staff roles, or if you just want to, I don't know, buy enough scales to put a scale in every room so you can do vitals in the room, finance people can come in and again, you can help them understand the project in the team meeting, but they don't have to be on the project team forever and ever. So yeah, so all of the above. And then we have another poll question where you'll go to the chat or the question box.
Yes, if you can please use your question box. What was most interesting or surprising about the QI team meeting that you overheard today? If you can please enter your responses in the question box. And also while you're there, if you just want to enter a few questions that you may have, we'll read the questions after this.
Yeah, thank you, Tiara. This is the last 8 minutes of the 3-part series. So please, anything that's on your mind, we'll try to get to it. And if not, we'll we can do some more correspondence by email.
Okay, well, we do have a question in the box for us, Hunter. We're still waiting on everyone else's responses. All right, first I guess we'll mention the comments. It said it was great to see a QI meeting in progress. Thank you very much to the entire team. How motivational Aaron was encouraging the team members.
Hey.
Great job, Aaron.
Yes, that's important. Yeah, if you're going to lead a team, you've got to have that energy. You've got to believe, right? You've got to believe in the topic you're trying to improve, that it's important, and you have to really understand the improvement methodology to educate as well as cheerlead. But yeah, Aaron did a great job.
So much cohesiveness among the team members. Sometimes that is hard to accomplish with teams.
Absolutely. We specifically designed this meeting to be of people who all actually want to be there, that they're interested, and they like each other. There's no nobody had a bad attitude. People had really smart reservations. Larry, said, I've seen this all before, and it hasn't really lasted. But he wasn't pointing fingers or being nasty about it. He was just making a good observation. Part of that with his role that we put in there was to acknowledge the fact that it's a mistake to label people resistors when we should think of them as the guardians of the good. Again, he said, we don't want to throw the baby out with the bathwater, and that's important. Sometimes people in the role of the excitable improvement lead, in Aaron's role, sometimes those folks, and I'm one of those, we can be too excitable and too ready to chase the new shiny thing. And we need people to balance that out and say, well, if we change this, something's going to happen over there that may not be good. We don't want to stop doing other things just to do something new. So yeah, so that was great. I definitely, I've got middle management experience myself, and I think it's really important to manage for attitude. If, get the right people on the team, you want to start with the willing. So if you're pulling a team of 4 together and you have a staff of, I don't know, 6 to 50, you want to pull together the people who really care about it and really are interested in new ideas. But at some point, you're going to work with people who are not the ones that are interested in new ideas. And there's, and the improved methodology really can help people find new energy and new steam for the work. They can really get excited because, oh, now we're finally looking at what the population needs. We're finally focusing on patients in a really smart way. So the methodology itself can help get rid of some bad attitude, but I do think, as a manager, again, back to my middle management experience, you need to manage for attitude. As a peer in a team, hey, that team meeting went great, except you seem to really be negative about everything that was going on. What's going on? How can I help you? But just observing people's attitude to them in a respectful way, and I would say in a one-to-one way. You don't want to call people out in a meeting because that embarrasses people and destroys trust. But anyway, that's some change management stuff we might want to get into some other day. But yeah, we designed this team meeting to not be among people who don't like each other or have bad attitudes or who don't care why they're in the meeting.
All right. Just going along with, sometimes it is, disagreeing. Someone said it's being able to disagree without taking it personal, which is good.
Yes, and that's part of what you want to do, and part of what we talked about here is you want to normalize disagreement. If we all agreed, if we all agreed, we wouldn't come up with new solutions. We wouldn't need to meet, and change would be really easy. We don't all agree, and that's important. So you want to normalize disagreement, promote disagreement, and then again help people manage the attitude and focus on the idea or the change or what's needed, the problem even. Focus on the problem or the change required or what the ideas are versus the person. So it's not that Erin had a dumb idea or that Tiara, is dragging her feet, but it's that you keep the problem in the middle. This is kind of if you think about Difficult Conversations, is a famous book about helping to manage differences and get people to work together. Difficult Conversations and books like that talk about putting the problem in the middle. And so it's not about you versus me or who's smartest or who's got the best idea. It's about pulling all the ideas together and also not me being I can't dig my heels in or somebody in Erin's role in the project. It's important for her not to dig her heels in, that she knows exactly the right answer and we need to do what she tells us to do. It's important that we be flexible and again, share ideas and inspire creativity and disagreement so that you can get to the goal.
Thanks, Hunter.
But I've seen QI really help with that culture change.
Great, thanks so much. So we do have a question. So what do you see what have you noticed are the biggest challenges you experienced in trying to implement PDSA cycles, and how did you solve it?
Yes, I'll try to be quick because I know we have a couple evaluation questions, Tiara. But the biggest thing is people don't want to slow down and talk about it. And they have a bunch of things to do. They're busy. They get an idea from somewhere, they think of it themselves, and they just want to rush to implementation. And 9 times out of 10, that either backfires in the moment, like we overwhelmed Tiara by giving her a huge stack of agenda forms and saying, okay, from today on, everybody who walks in is going to get an agenda setting form. And it confuses the patients, it confuses Tiara. Tiara gets turned off and doesn't want to play our reindeer games anymore. She doesn't want to be part of this agenda set business. So that's the risk, is that people rush to implementation. The solution, or how you help people, is it's good project management and good kind of communications. And part of what needs to happen, I had a recent project current project where one MA started testing a new process, kind of like agenda setting, we can say. So one MA started testing agenda setting. She got excited about it. It was really cool. She and her provider, it was really working for their patients. They were referring more people to nutrition services. All this stuff was going on. She told the other MAs, and all the other MAs just started doing it. And it caused total chaos. Some of the providers got mad. And so part of what you need to do to help people follow the methodology and do PDSAs is to tell make sure the rest of the clinic knows what you're doing. We're going to do over here in this corner, and on some days with some patients, in this little corner of our project, we're going to do things differently, and we're figuring it out on your behalf. So we need you to wait. So part of the problem is patience, and part of the solution is education.
Thanks, Hunter. That seems to be all the questions that we have for right now. We definitely want to encourage everyone, if you have any questions, please go ahead and enter in the question box. And those that we're not able to get to, we'll definitely make sure that we will get to your questions via email. Since that seems to be the last question at the moment, as you can see on our screen, we encourage everyone to please become a member at School-Based Health Alliance. In addition, our members receive exclusive access to valuable program tools, timely publications, and networking communities. Please take a moment after the presentation to visit our website at www.sbhforall.org/membership for more information. We encourage everyone to please join. We do have a few poll questions that we would just like your input to ensure that we are definitely meeting your needs. Our first question, did this presentation meet your needs? If you can please take a few seconds to answer the question. Thank you. Our next poll question is, how well did the presentation meet the stated objectives? All right, thank you, everyone. Our next question is, how likely are you to apply information from this presentation in your organization? And would you recommend this webinar to others? Thank you, everyone, for attending our webinar today. A special thank you to Hunter Gatewood for this amazing series. We have learned so much. We appreciate you for including SBHA for our improv skills.
Y'all were great.
And we look forward to, of course, continue working with you. Again, everyone, we appreciate. And if you have any additional questions, please send them to info@sbhforall.org. And we will send the agenda template. This is being recorded. We will also send the slides with the recording when it's updated to our website in 3 to 5 business days. Again, we thank you and have a wonderful day. Thank you, Hunter.
Bye, everybody. Thank you. Thanks, guys.